TA Network's Clinical Distance Learning Series. I'm Christopher Balanci, and I'm leading this initiative on behalf of the Substance Abuse and Mental Health Services Administration, or SAMHSA, Center for Mental Health Services, Child, Adolescent, and Family Branch, along with the TA Network. We're excited to offer this first-of-its-kind training series for System of Care grantees. The purpose of the clinical series is to identical assistance around the latest innovations in child and adolescent clinical interventions. Our goal is that the series will appeal to a broad audience, including youth, families, clinicians, and administrators, allowing all interested stakeholders in your community to gain convenient access to the latest information on best practices in child and adolescent behavioral health care. We've had a great response to the survey, thanks to those of you who have completed it, asking for your feedback on what you and your community is interested in learning about related to clinical interventions in children's behavioral health. If you did not complete the survey, in the chat box accessible to everyone on this call, I put in my email. Feel free to shoot me an email if you've got a topic of interest or a specific speaker you'd like us to have present. The feedback is going to be used to guide the development of future trainings and the TA offered as part of this clinical series. We're going to keep you updated through the TA Telegram about all the upcoming programs that the series has to offer. The next one up will be on red flag and response systems for oversight and monitoring of psychotropic medications, which is being presented by another TA Network partner, the Center for Healthcare Strategies, and that's scheduled for October 16th from 1 to 2:30 p.m. Eastern Time. And in November, we're going to be launching a 3-part webinar series on substance abuse and co-occurring disorders. So please stay tuned. With that overview of the clinical series, I want to introduce the Early Assessment and Support Alliance at Portland State University. We're thrilled that EASA has agreed to partner with us to present this series, and this is the third and final in the series. And to introduce today's speakers and the topic, Janet Walker is the lead for the TA Network at Portland State University, and will be doing the introductions. Thanks, Janet.
Thank you so much, Chris. Welcome to everyone who's here on today's webinar. As Chris mentioned, this is the third in the Clinical Learning Exchange series on early psychosis intervention for teens and young adults. And today's topic is transforming systems of care for early psychosis, a step-by-step approach. Just quickly, as Chris mentioned, I am the lead here at Portland State University, and that would be the Portland in Oregon, for the Technical Assistance Network for Children's Behavioral Health. And that means I am the liaison at PSU for several centers and initiatives, including the Research and Training Center for Pathways to Positive Futures, the National Wraparound Initiative, the Reclaiming Futures Initiative, and most relevant for today, the EASA Center for Excellence, which provides technical assistance, training, and other forms of support to EASA programs around the state of Oregon and to entities nationally. So you'll be hearing a lot more about the history of EASA and what it does, the Center for Excellence does during the webinar today. It's been my pleasure to be affiliated with the Center of Excellence's work since it was created at Portland State a little over a year ago. And it's also my pleasure today to introduce Tamara Sale, who is Director of EASA Center for Excellence at Portland State. Also starring in today's webinar is Dr. Lisa Dixon, who is the Professor of Psychiatry at Columbia University Medical Center and Director of OnTrackNY. So without further ado, Tamara, if you would take it away.
Great. Well, thank you and welcome everybody. This is our last webinar for this particular series. And also on the line with us is Dr. Ryan Melton, who did webinar 2 and is our clinical expert for the EASA Center for Excellence. I also want to remind everyone that we have a follow-up phone call on October 6th from 2 to 3:30 Eastern Time. And also all of the previous webinars and calls, along with video links and handouts, are being posted to our website. And everyone will have a copy of this PowerPoint at the end of the presentation, so you'll have all these links. Lisa, you want to introduce yourself?
Hi, everybody. My name is Lisa Dixon, and it really is an honor to be here with you today, sharing our experience and hopefully learning from each other about our work in early intervention. I am a professor of psychiatry at Columbia, as has already been said. I was a principal investigator of one of the RAISE projects, and now I direct OnTrackNY, and I'm really excited to share some of what we've learned with you.
And again, I'm Tamara Sale. I'm the director of the EASA Center for Excellence, And as I had mentioned in webinar 1, I've been involved in helping to coordinate, develop training, et cetera, for the Oregon effort since it began in 2001 till today. So today we're going to cover an overview of the coordinated specialty care concept, which is the construct that was the basis for the RAISE programs and also is the kind of underlying construct for the current rollout using the federal block grant funds. And I think it's very consistent with the international standards that have been developing. We're going to talk about the steps in creating a program, and we're going to use our experiences within EASA and RAISE/OnTrackNY York to illustrate those steps and talk about the decisions that we've gone through making over time. And then we'll also talk about ongoing resources for everyone on the call.
Okay, so this is Lisa again, and I just want to give a little bit of a slightly deeper background on this notion of coordinated specialty care, which is a relatively recently coined phrase, and as Tamara mentioned, it's kind of come to represent, I think, two things. One is the range of evidence-based practices that have been tested and used to support the recovery of young people experiencing first episode psychosis, both nationally and internationally. And so it has great specificity and evidence underneath it. On the other hand, it also is flexible and elastic. And in its articulation on the NIMH website, there is a lot of room for creativity and growth and evolution in the specification of coordinated specialty care. So coordinated specialty care has really come to represent, the phrase that has come to represent sort of the best that we can offer right now in the care of young people experiencing first episode psychosis. And as such, it really has strong support from the NIMH, from SAMHSA, and other national organizations. In some sense, it's come to represent a movement. There are many existing programs with significant experience providing coordinated specialty care in the U.S., and certainly, and you'll hear about them today. And as this movement has unfolded, I think, very excitingly, we've seen concrete steps taken toward national coordination of sort of the national rollout of this model. And I think this webinar is an example of how that's taking place. And finally, as this kind of national coordination is unfolding, we're beginning to see the emergence of really a learning healthcare system so that we can all, the ideal being that we all kind of learn from each other and contribute. And I think we're going to see more about that in the future. Very concretely, coordinated specialty care includes the following sort of clinical concepts and ideas. A rapid response team. This is not the kind of program that sits back and waits for people to come to it. And when it is called, it responds right away. It is embedded in a larger system and a community of care. Again, it's proactive. It seeks out people needing support and also facilitates services for those who are not eligible or who are screened out. And again, one of the issues that we're going to be wrestling with a little bit today is, for whom are these services appropriate? It's intensive, although I would add that its intensiveness needs to be moderated by a collaborative process. So if individuals don't want the intensity, then they don't need to have it. It really is person-centered and collaborative. It's an integrated approach with multiple disciplines. And again, it's a learning healthcare approach with services based on evidence, participatory decision-making, and with a very strong and clear and proactive focus on outcomes. The components include team leadership, case management and psychotherapy, both individual and group, supported education and employment, family education and support, pharmacotherapy, and primary care coordination. And I think you can see that in these sort of labels, there's some room for flexibility in how we specify the psychotherapy or the family education and support. And you see a wonderful document that describes coordinated specialty care. It's a great summary that's in the link on this slide. And finally, we picked a quote that came from the Raise Connection qualitative study that we did talking to individuals who received services. And that really demonstrates that the overarching theme of CSC programs are that life goals are the guiding priority for the services. I guess what's been good about the program is hearing the counselors talk and saying this is not defining who you are. This is an event in your life. You can still get on with your life. You know, there may be some differences, but you can still do it. And that is a quote from one of the service recipients of our project.
Okay, so we're going to talk about the steps in creating a program, focusing on the individual experiences that we've had, focusing on gaining buy-in, issues around population and eligibility, program structure, services and financing, and then training and accountability. Okay. So again, EASA began as a 5-county managed mental health care initiative in 2001, spread to a statewide dissemination effort, which is still ongoing with a particular focus now on our rural areas. And the EASA Center for Excellence was created to help coordinate, provide training, practice guideline development, et cetera. And so EASA has all the same CSC elements that Lisa was describing. Again, kind of coming out of the literature and kind of evidence-based practices around the world. A few things that I wanted to focus in on are, first of all, that EASA has chosen to make the services available universally regardless of insurance. Also, alcohol and drug treatment is provided within the team, which I believe is true for most CSC programs. And we've included occupational therapy, RN level nursing, and peer support within our model, which again is very consistent with the CSC, but a decision that we've made. And we also have a very strong emphasis on participatory decision making with a section focused on that in our practice guidelines. Our teams are currently available to 90% of the state population, the remaining population being primarily located in highly rural areas. We've served over 1,100 individuals and their families since 2008. The penetration rate per year at this point is about 0.77 per 10,000, so we'd like to go beyond that, but it gives you a sense of where you may be shooting for. The majority of folks in our program are in school or work. At the point of discharge, 58% of them are not planning to apply for disability. We have strong family participation. So we have some good beginning steps or beginning outcomes that we are continuing to try to build on. We have a pretty hospital graph like virtually every other early psychosis program out there, and this is one of the best selling points because the legislators love these types of graphs that show a higher level of hospitalizations coming in and an immediate precipitous drop-off. We also are trying to reduce that initial level of hospitalization, so 42% is actually lower than it's been in the past. Okay, so walking through the steps, building ownership is a really big part of what you have to do in the beginning as well as you expand over time. And I recommend, if it's at all possible in your local effort, to try to identify a full-time person who can take on that role. That's been my entire job since 2001, and I think that has made a difference in our ability to actually have the continuity and the level of effort that's needed. Also, the leaders who you're going to involve in getting your program started need to understand what they're trying to create and also what their ongoing role is from the very beginning. It's very helpful to involve people who have lived experience, and I'll talk a little bit more about that. And also, I really encourage people to think about those areas where you don't quite know how to get there. So if you want to serve the whole population but you don't have the funding, or if you need to get out to the schools, but you don't know how to reach them, invite folks who are better positioned to the table to help you. So we invited our Director of Mental Health and our Director of Voc Rehab for the state to our Sustainability Task Force starting in 2002, and that led directly to our legislative appropriation and also funding from state VR. There are a number of areas where you can find some significant traction in building the support. The voice of people with lived experience is incredibly powerful. Family stories can really illustrate why a program is needed, as well as bringing in the voices of folks who have directly experienced these types of services. Those stories tie really nicely into the overall recovery focus of the system. And then on the economic side of things, you see that a large percentage of people are hospitalized, they get rehospitalized, they go to the state hospital, and so you can make a pretty strong argument that we're spending a huge amount of money without getting good outcomes. And also, we have the Olmstead decision, which basically gives people the right to the services they need to stay out of the hospital. And in fact, the Department of Justice has included EASA in its requirements for the state of Oregon, so that Oregon actually reports on a regular basis how many people have received EASA services to the Department of Justice. Of course, we all have mandates around evidence-based practice or prevention. And then finally, another area where there's some significant traction is the triple aim under healthcare reform, focusing on the combination of individual quality, population health, cost. This type of model is perfectly adapted to that particular framework. Getting back into the kind of practical logistics, talking about population and eligibility, Lisa will talk a little bit about a tool they developed to help project out what your annual incidence is likely to be. So that's a very helpful thing to think about. And you also have to think about what diagnostic spectrum are you going to serve. We started off in the beginning with schizophreniform. We added bipolar spectrum because of the difficulty of differentiating between bipolar and schizoaffective disorder. And then we ultimately moved into serving psychosis risk syndrome. We've chosen not to include other psychoses like depression, et cetera, primarily because of the types of services that those folks need, which are somewhat different, and also just the number of people and the volume. You will experience, no matter how you focus your program, that there's significant diagnostic uncertainty in the beginning. So people will graduate from your program with a range of diagnoses, which include your primary focus, but also go beyond that, and that's to be expected. You also have to think about what your age range is going to be. And at this stage, EASA has a minimum standard of 15 to 25, although it is a guideline, and we have programs that serve down to age 12 and some programs that serve over age 25. You also have to decide whether you're going to have any funding restrictions. So some programs have tried to implement using just making it accessible to Medicaid individuals. I would recommend, if you can possibly avoid doing that it's much more consistent with the intent of the model to make it universally accessible. Speaking about structure and services, where's your program going to be located? That's another key decision. You really want an organization that's going to provide some leadership, that's going to be really committed to it, that has a good linkage to existing crisis systems, existing referral structures, and also that's going to be able to maintain the level of staffing intensity, the coordination, and the flexibility that's needed. So if they have a huge caseload on one part of their caseload and then an intensive caseload for the early psychosis piece, that's going to be really problematic. So every community has to kind of think through what works the best for them. Community education is a huge element of this, so be sure to think about it from the beginning. If you don't do a lot of community education, you won't get people in your program, or they'll get to you much later. Also, one of the things that people sometimes forget is that there's a significant screening element to this. We screen out a third to two-thirds of the people who are referred to our program. And so we actually also talk about ourselves as a community consultation and brokering service, so that those folks who refer to us who have inaccurate referrals see us as a resource for kind of a little bit of early differential diagnosis and figuring out what the appropriate fit is. We're shooting for an intensive level of care, which is about 1 to 10. That's across the team, not per clinician. So if you have 3 FTE total across your team, you could serve 30 people. You can expect that when people first come into your program that they're going to have more intensive needs. You do want to pay attention to whoever's providing the lead clinical role, and try to maintain some limits on their caseload. We recommend no more than 1 to 20 or 1 to 25, and that is assuming that they have a combination of the more intensive folks and some folks who have been in services for longer who have less intensive needs. Of course, the team is going to be reviewing everyone weekly, so it's similar to an ACT team in that respect. And the whole team, every member of the team, serves individuals who are below 18 as well as above. One of the other questions you have to answer is how long is your program going to last? We started out as a 3 to 5 year program, changed to a 2-year program, thinking that that would keep the focus more on transition. But we also have been working towards developing longer-term supports, because the research really does support maintaining some kind of longer-term check-ins or programming for people in order to keep them from falling through the cracks after the fact. And also our graduates are just amazing resources for the newer folks. Some of the things that you have to think about are that you don't want people to take on the identity of a permanent patient of the public mental health system necessarily. And you also really want to manage people new coming in. So you don't want to end up with waiting lists or long delays to get into your service. And then you'll also want to develop a transition process. That might not be the first thing you do when you start a program, but as people move out of the program, it needs to be kind of a long-term transition, very well planned with follow-up check-ins. As you choose who to hire in these programs, you want to make sure they're there because they want to be, that it's in their job description, which you wouldn't think you'd need to say, but that actually is a big issue. And with strong supervisory support, particularly around issues of productivity, which often come in conflict with these programs, and the ability to be flexible, making sure they get the training, that sort of thing. The financing, what you'll find is that the program will build over time to the point where it hits kind of a plateau, and then it tends to grow incrementally from there. You want to make sure that you have enough people in your program to not go below a 1 to 10 ratio, because otherwise your costs get just way too high. We recommend really trying to pursue a diversified funding model, so including public but also private sources. We use some voc rehab funding, and you will probably want to try to project out what your anticipated revenue is going to be and what your level of need for subsidy is, and then again work with the other stakeholders to get to the point where you're sustainable. We are working within Oregon and also nationally to look at alternative methods of sustainability, including things like expanded Medicaid eligibility. We've piloted a case rate process in our metro area here. There are other methods like bundled services, et cetera. And of course, training and accountability is really huge. You need some kind of ongoing training, consultation, coaching, looking at whether you're actually implementing what you said you were going to implement, and then measuring some kinds of outcomes. And again, there is a national discussion right now about kind of common outcomes across states. So with that, I'm going to turn it over to Lisa.
Thank you so much, Tamara. It's remarkable to me how similar the lessons learned that we experienced in New York and Maryland, how similar they are to what Tamara described. So I'm going to really, I'm not going to repeat what Tamara said, except I may have a slightly different emphasis in our story and maybe emphasize some of the wrinkles of our own experience. So I'm going to be talking to you about OnTrack New York, and our story and our development was different from Oregon. We're a newer program, and we started with the Raise Connection program, as you can see from this slide, which really allowed, with NIMH funding, allowed Maryland and New York to develop an optimized coordinated specialty care program, a program that essentially met the requirements, which we'll talk a little bit more about. We included individuals who were between the ages of 15 and 35 who were within 1 year of the onset of non-affective psychosis. And over the 2 or 3 years of that project, we demonstrated good community buy-in and feasibility and positive outcomes. And so both of our states, both New York and Maryland, were really interested and motivated and really excited to extend the original RAISE project. And in New York, we named it OnTrack New York, and that was a very intentional name. Anybody's welcome to it. We wanted a name that would convey the goal and the spirit of the program, and so OnTrack is really kind of what we hope we're about. In the original rollout of OnTrack New York, we had 4 sites, and again, I'll be talking a little bit more about the challenges of creating those 4 sites. So this was not a statewide project. In fact, what the strategy of New York was kind of to start small, get experience, and then to sort of build wisely. So that's really kind of alternative strategy to kind of trying to do a statewide process. And now, with some additional funding, we're poised to increase to 12 sites and cover a lot more of the state. So this is what the RAISE Connection team interventions looked like. I think this is probably very familiar to a lot of you. I just want to emphasize that the whole endeavor was really circled and embedded within a shared decision-making frame, which is something that was hard, I think, for a lot of our clinicians to learn, but they learned it and they loved it. And so within that frame, we offer a lot of different kinds of services that individuals can partake of or not within a team-based model. And each of those services, as you see, like medication, support, education, and employment, is also kind of attached to an outreach and engagement philosophy. And ambivalence is such a natural part of the perspectives of these young people. And so, we expect that they'll pull away and pull towards over time. And so we always have this notion of shared decision-making and outreach and engagement. The original model was 2.7 FTE to serve about 25 young people. So OnTrack New York, you can see here our logo and our tagline and our positioning statement. And I showed that to you, again, because I think a key lesson that I know EASA understood well and that I wanted to emphasize here is kind of our language and our messaging. My health, my choices, my future. And our positioning statement on OnTrack New York as an innovative treatment program for adolescents and young adults, et cetera, doesn't use the word psychosis. We use descriptive language, not medical language. And so that's a lesson here is particularly in our early communications with the individuals we're hoping to engage and serve, we have to be really careful to use language that isn't going to scare people away. Once we're working with them and we have a relationship, we certainly, talk about we answer people's questions, and we use the medical language as it's appropriate and as we think it's going to be helpful. But in our communications to the world, we try to be engaging and inviting. And some of the medical language is really scary. So here's another publicity material that we use. And again, we're happy to share this with any of you. Governing principles of OnTrackNY, again, very consonant with the coordinated specialty care model, fundamentally focusing on limiting disability, recovery, and shared decision making. And these things seem very, these concepts seem very simple now and almost apple pie, or but the ongoing supervision and training, it's really important to live it and to embed it in all the dialogue and discussion that the teams have together and with their clients. So just in terms of how OnTrackNY evolved from RAISE, is again, it's grounded in a critical time intervention CSC model. And we use the word critical time intervention to emphasize that, again, this is not a service forever, and we'll talk a little bit more about the time limitation that we had to wrestle with. It's multi-element, developmentally flexible, and again, as Tamara said, it's really important that these teams serve both children, in the child system, and young adults. And one of the administrative barriers that I think our teams had to deal with, and many of yours will as well, is overcoming those kind of artificial, unfortunate divisions between the youth system and the adult system. And we required that all our programs be willing to do what needed to be done administratively to serve children, technically children and adults. The program is, we focused on situating these programs in non-stigmatizing space. We focused on cultural competence. Our FTE went up to 3.5, and I'm happy to say that we're right in line with what Tamara said in terms of that number of FTEs serving approximately 35 young adults. Again, the program is capable of outreach, but largely office-based, and that's kind of a complex set of concepts there. The programs definitely can do outreach in the community, and certainly supported employment and education, almost by definition, takes place in the community. But I would say, having been worked on ACT teams and very familiar with ACT, that we actually try, if we can, to provide the services in the office because it's more efficient that way. And we also are trying to work with our service recipients to kind of learn how to manage whatever their illness turns out to be for the long haul. And in our system, that largely involves coming to the office. So there's outreach capacity, but I'm emphasizing this because I don't want you all to think that all of these services take place in the community. I think it's actually a challenge now to figure out how much should be in the community and how much should be in the office. And again, these services are highly individualized. Just to sort of give you a sense of where we are today, again, we're a young program. We've been up and going for about a year. We're serving 85 young adults. You'll see, again, the average age is 20, about a quarter are under the age of 18, largely a little majority male, and I think that's fairly typical of these programs. Very culturally diverse. That's a reflection of where we are in New York. And our average time from the onset of psychosis to OnTrackNY is 5 months. We'd like to get that shorter, but again, it's always a work in progress. Here's some of our data. Again, you see that lovely drop in hospitalizations. You'll notice that our clients started with, almost all of them had a hospitalization before they came to us, and that reflects a little bit the state of affairs here, that people largely get to care through the hospital, and that is, again, something that we would very much like to change. On the other hand, you can see that we were able to bring about fairly dramatic reductions in hospitalization. And then this slide shows you the rate of participation in worker school over the program tenure. And so that, again, we can see that almost 90% by 9 months are in work or school. And this is not easy, and it's a challenge, and we're very proud of these outcomes. Okay, so setting things up. Again, very similar to what Tamara said, identifying the lead. So this was really at the level of our state. Those of you who are on the call, maybe you guys are the leads, or you're thinking about who is going to be the lead in your state. And the bit of advice I would give on that is build on existing strengths. Build on strengths. Every state has strengths. Every state has some center of excellence or talent. In New York, because where I was, we had done the RAISE project, and we have an ongoing relationship with the state, and we have an evidence-based practice center. They situated the OnTrackNY within our center. Develop a steering or leadership group with diverse stakeholders. Again, as Tamara said, this is an endeavor that requires that will be optimized by the input of the different stakeholders who care deeply about this, and that includes consumers, families, service providers, payers. And so we developed a couple of advisory groups that meet regularly to review the program, to problem solve, and also to whom the program is accountable. Again, understanding revenue sources and create a budget. This is probably the starting point. Again, in New York, I think one lesson here is that the financing doesn't have to be perfect from the beginning, or it will evolve over time. And again, I'll share with you a little bit of the thinking of New York in our pilot shortly. And then considering overall population needs, as Tamara mentioned, we've developed a tool that's an Excel file. It's really easy to use, that will allow you to plug in your population. It will allow you to plug in assumptions regarding incidence. So if you want to serve just people with schizophrenia, you can plug in an incidence number that reflects that. If you want to serve a larger population of individuals with all psychotic disorders, you can plug in a number that reflects that. You can plug in a number that reflects how big your teams are going to be, how costly they are, and that will give you a lot of information for planning. So what were some of our decisions? Again, New York decided to go with a pilot, to start small and then gather experience. It chose to do 4 fully funded teams. We felt at that time that dealing with billing and reimbursements and budgets and shortfalls was something that the state didn't want teams to have to deal with that, and there was sufficient resources to fully fund a small number of teams. And then the idea would be that we would acquire knowledge about how to bill and finance moving forward. In terms of where to place teams, the decision was made to start in the downstate area, which is, probably most of you know, is much more highly populated than the upstate area in New York. The reason for that was really efficiency, to capitalize on regional proximity for training and to capitalize on population density and cultural variability. We were very interested in sort of testing out this model and sort of giving ourselves kind of a really crash course in culture, and that's what we've done in the downstate area. And we also chose to site our 4 programs in very different kinds of agencies. We have one state hospital, one city hospital, one private not-for-profit freestanding outpatient clinic, and one large hospital program that's also private not-for-profit, because we wanted to get experience. And again, I think particularly if you're a state that, again, you're going to start small or you're going to sort of do this incrementally, it would be important to think about kind of what you need to learn in order to scale up. Some examples of criteria for site selection are very similar to Tamara, so I won't go over that with you. I think this is critically important in terms of the choices you'll make. So what were some of our other key decisions? And I'm going to go through these one by one with a slide. So focus of outreach, eligibility, model components, treatment lanes, training, fidelity, and data collection. So the outreach. Now, this slide shows you kind of a diagram for the pathway to care. It starts with help seeking, to referral, really starts at the onset of psychosis, to help seeking, to referral to mental health services in general, and then referral to early intervention services. And this is what we chose to do in New York. You could choose to do a lot of community education and try to influence the point at which help seeking occurs. We wish that we had the resources to do that at the front end in New York. We felt that we didn't. Again, given also the size of our community in lower New York State. And we were also worried about creating so much demand that we couldn't meet it. And so we were sort of cautious about doing a lot of community education to promote help seeking. And we were also aware that there was a huge need in early intervention services that could be sort of timed after someone kind of began to make it into services. And so what you're going to see here is that our initial target for outreach was really to start once people had kind of made it to the mental health system but hadn't made it to appropriate services. And so our future will be to do more of the reaching back into the help-seeking phase. But again, for efficiency and also just to kind of conserve our resources, and because we knew that we had a pretty big population that needed help post-referral to mental health services. And so that's why we focused there to start with. And again, also being very mindful of criminal justice and child welfare, so that we felt we had a fairly significant client base to start with there. Okay, eligibility. Again, Tamara's already alluded to the decisions around, do you include people with all psychoses? Do you include people who are at risk for psychosis? In New York State, we decided to focus on non-affective psychosis. And then there's a lot of kind of technicalities regarding how you define that. In some research studies, the first episode is actually defined by previous treatment, so the lack of previous treatment, whereas in other studies or in other programs, it's time since onset of illness. So you could have someone who's been ill for 3 years but has never had any treatment, and that person in one approach would be first episode, but that person wouldn't be first episode if you were restricting by time since onset. So again, there's no right or wrong answers here. In my heart, what we really want is to provide as many services as possible to the people who need them. But in our implementation, we had to make some decisions, mainly because of restricted resources. And so what we decided to do was to confine or restrict our eligibility to individuals who were within a year of the onset of non-affective psychosis, in part because of capacity, and in part because we thought that the literature suggested that was where we'd have the biggest impact. Again, model components, the CSC really defines that. I just want to emphasize some of the challenges and questions that we have struggled with. Again, one is including peer support workers. We did not have peer counselors in our initial model. We are now adding them. We think it's very important, and we're thinking about, in particular, focusing our peer team on helping with issues of transition. There's been a lot in the wind about cognitive remediation, trauma treatment. I emphasize this in order to let you know that this is a living, breathing, dynamic process, and that we don't have all the answers now, and this whole endeavor needs to kind of keep growing and living and breathing with research and with our sort of practice-based evidence as well. Treatment length, again, we would love to have had an open-ended model, but in our state there was no way they were going to let us kind of create a parallel mental health system. We really don't know how long these programs need to be, and we set ours such that individuals would be in treatment for an average of 2 years. And so what we appreciated with that is that some people would be shorter and some people would be longer. And again, we're working actively. We have a manualized approach to this transition process and conducting follow-ups, and really the goal being, to give people, to work with people to develop the tools, to sort of manage whatever their illness is through time with what services they receive next. And finally, the whole issue of tracking outcomes, this has to happen. We're accountable to ourselves. We need to use data to understand how we're doing and to see where we're falling short and where we're doing well. So what we did in this case was we rely on quarterly reports by the team. So the team leader with the team, essentially at the time of treatment planning, does a brief quarterly report on the status of the individual, and those kinds of reports are very easily aggregated. We decided, in part because of resources, that we could not afford extensive site visits, but we do very brief site visits, sort of in the spirit of trust but verify. I don't have a lot of time to talk about training, but I just want to emphasize that you have many choices, and there are many good choices. I would just say that it's important to seek out some external expertise and training, but that the supervision and the support, whatever you get externally, it's really important to have an internal structure of learning within the agency, and also really supporting these clinicians who are working very hard. It can be quite stressful. It's really, really rewarding, but it's very important to pay attention to that sort of ongoing support for the clinicians working on the program, and that really can come from inside the agency and from leadership within the agency. So we wanted to take just a few moments to share what the RAISE Early Treatment Program offers, which is, again, a phenomenal program called Navigate. It was implemented at half of the early treatment sites for the RAISE Early Treatment Research Program, and I can vouch for how great they are, and they actually also helped us in our development of RAISE Connection when we moved to OnTrackNY. You can see the map as to where these sites were. It's based on a stress vulnerability model, emphasizes recovery and resiliency, uses CBT strategies, including cognitive restructuring for hallucinations and delusions, principles of illness management, and it is informed by special issues for first episode psychosis, including, again, I think you'll hear the echoes of what you've heard before. And each component of Navigate has a manual and a training package, including the director and family clinician, prescriber, supported employment specialists, individual resiliency training clinicians, and sometimes a peer specialist and or separate case manager. And again, the contact information is included on the slide. And finally, this last slide includes links to some of the material that we presented here today, and other leading centers that are providing these CSC types of services. And one last thought, I think both Tamara and I alluded to this kind of emerging community of people, clinicians, individuals experiencing psychosis, family members, who are trying to make this, trying to create this international learning community. And there are a number of networks which you can join, and over and above the training that you might want to receive. And as Tamara says, the problems we face have often been solved by someone, or will be soon, and synergy increases the speed of change.
So we do have an initial question from Sandra Steingard about whether we have any follow-up data for folks post-treatment through EASA or OnTrackNY in terms of hospitalization rates compared to treatment as usual. I know within EASA we haven't had a good system for longer-term follow-up. We certainly hear anecdotally that people are generally staying out of the hospital. I think there's a small group of folks who have much more intensive needs, which is generally true during the program and sometimes is true after. But most folks are staying out of the hospital longer term, and I think that would be a good area for us to do a little study. Lisa, how about you? Do you have anything like that?
Yeah. It's a great question, and it's a critically important question. And I think that the answer to that question, is going to have, it'll be a function of, again, the actual services people received while they were receiving these specialized services, and then also what they received afterwards. We're kind of not, we're still relatively new in this game, but I will acknowledge that we've not had the funding to systematically collect information on what has happened to people after they've left, and that is a problem that we are in the process of correcting. We really have to know this. We have to understand it. So I'm sorry to say I don't have systematic data on that question. Again, anecdotally, we've kept in touch with lots of people, and we're hearing great stories, but that's not the same as having systematic data.
Yeah, and actually Sandra is now clarifying that, in fact, what she's really more interested in is the rate compared to treatment as usual for folks who are in the program. Mm-hmm. So do you have anything like that?
Oh, yeah. Well, so there, the challenge there is, to have some kind of concurrent control, whenever you're neither of our programs have a reasonable control condition that we've been able to follow. But if you look in the literature on hospitalization rates, sort of in treatment as usual, I think you can say that they're, very, substantially lower than what has been seen in treatment as usual. It is true that hospitalization rates, if you start at hospitalization, regression to the mean will essentially, the hospitalization rates will also go down in treatment as usual. But if you compare the hospitalization rates in these programs, they're definitely lower than what you would see in treatment as usual, maybe by a factor of 2 or 3. It's hard to know exactly because the samples are different.
Yeah, we took a look at the hospital association data and tried to do a comparison group analysis, and like Lisa was saying, the comparison group becomes kind of an issue because there's so many different variables that go into hospitalization rates. And what we're finding in the Northwest generally is that hospital rates are declining overall. The original 5 counties that were part of BCN showed a really precipitous drop from the time of the inception of the program. But again, we can't necessarily say that the program was the only contributor to that. There is a study that Yale did that is about to come out that randomized privately insured folks between a specialty care clinic and treatment as usual, and they did find really significant differences in hospitalization. So I've been kind of staying in touch with them to try to, in the hopes that we'll see that publication soon. And I think that at the national level there may be some data where they've used the Medicaid database to try to also get at these questions. Because it certainly is something a lot of people ask, and we've tried to pull something together that was conclusive and haven't yet been able to do that.
I mean, the RAISE early treatment program has used a cluster randomized design, and they should have reasonably good data comparing their Navigate sites to their control sites.
Right, that's a good point. Okay, so could you share the tool that you use for gathering data for the quarterly reports? Sure, yeah. We could definitely give you copies of the tools that we've used. We've actually made some recent changes because some of the questions we've been asking have been integrated into the state data system. So what I might do is to send you our older version that you can look at. And Lisa, do you have data collection tools you can share?
Absolutely, yeah. And you can pick and choose. One of the things that we're really working on is we know how clinicians get burdened with data. They hate providing data. And so we're trying to make sure that every single data element that we collect has is important and essentially becomes useful to them. But I think it would be the kind of thing where you want to pick and choose for your own program.
Right. Yeah, and again, that learning healthcare system discussion is going on with the idea of trying to have some standardized indicators across communities. And there's also been some international work done on kind of what would be considered key indicators, some of which we don't track, honestly, because a lot of them are population level. But we can share the link to that article as well.
On the subject of the indicators, or on the data, I'd say that we collect two kinds of data. One is data that focuses on outcomes, like is the person working in school, has the person been hospitalized. But then we also collect some data that will give us some sense of fidelity. So we'll ask, has the family been seen in the last 3 months? Has the person worked with the IPS worker? Has the person been offered an antipsychotic medication? Is the person receiving medication? And what we're looking for is evidence that the model is being delivered. And one way that we know that we have more confidence that the model is being delivered is if nothing is 100%. In other words, if we find that there's a component of service that everybody is taking, this is a little bit, I'm being a little tongue-in-cheek here, but we've found that there's virtually nothing that everybody wants. So if it's 100%, we would be worried that it was being pushed too hard. And so we're looking for some kind of balance, suggesting that our teams are really using shared decision making and they're really paying attention to choice.
Right. So yeah, Jen was saying that was her next question. Is there a fidelity tool that everybody is using? Question for each of us. Our practice guidelines, which are on our website, include a fidelity tool as part of the practice guidelines, and we actually do an on-site process generally every couple of years and encourage people to integrate it into their quality improvement process. It's an iterative tool. At this point, it's pretty comprehensive, maybe a little bit too much, and so we periodically go back and revisit how it's laid out, and we'll probably be doing that again in the next year. We're also doing some collaboration with Don Addington up in Canada, who's developed the fidelity tool kind of based on an international consensus process that he's done, and so I expect that will lead to some changes in our tool. So Lisa, I don't know if you have any additional.
Yeah. I can share with you our approach to fidelity, and again, it's a little bit different than I think some of the more formal traditional approaches to fidelity, in part because we wanted to have an approach that could scale up. So we tried to have a fidelity process that could almost uniformly be done with essentially with administrative data, with data from these reports. It's not going to be perfect because you're never going to really know is the session being conducted exactly how you want it to be. It's very hard to get in the consultation room, so to speak. But again, it's sort of not letting the perfect be the enemy of the good, and getting some sense of fidelity in a practical, feasible way. But I'll be happy to share with you our approach.
Yeah. So Sandra also asked, how do you address the use of antipsychotic drugs in either of your programs? Do you want to start with that one, Lisa?
Sure. We start, so one thing to be aware of is that the OnTrack New York programs and do not include people who are at risk, clinical high risk. They're people who have an established psychotic illness. But that being said, shared decision making is the guide. We kind of view all of these decisions as preference-sensitive decisions, and we appreciate that. While we appreciate on the one hand that there is a tremendous, important evidence base for the effectiveness of these antipsychotic medications for the reduction of psychosis in a large number of people. At the same time, we appreciate that. That again, this is something that individuals have a right to choose, and they have a right to choose given the data and the information. And we work very closely with Pat Deegan on this, and she's really guided us in our work around sort of the dignity of risk and the duty to care. And so in the end, the majority of the individuals we serve do agree and are interested in taking antipsychotic medications, but not everybody, and care is provided regardless. And we just work with people to manage their situation. Does that, hopefully that answers your question.
Yeah, I think that we take a similar approach. Obviously, shared decision-making is a really critical part, and it also is a team effort, so we come at it from multiple angles. As Susan had mentioned in her slides, we use a stress vulnerability model with the idea that there are things that are going to increase your vulnerability to psychosis and things that decrease it. And so medicine is viewed as a way of decreasing vulnerability. We require our programs to have accessibility to a prescriber within a week, and we expect the prescriber to meet with the individual even if the person chooses not to take medicine. And we also have a section, again, in our practice guidelines on prescribing, which we find is pretty consistent with people's general practice anyway, around starting low, with low doses and building upward, trying to avoid polypharmacy, and then considering, after a period of remission, considering a gradual titration. So we do have those guidelines. I think when you have people coming in from a hospital setting, the antipsychotics often have already been prescribed at a much higher level, and so we're often trying to bring people down to a lower level. But ultimately, what we're shooting for is for the person to be engaged in their own decision-making process where they recognize the need for medicine as part of their recovery. And so that requires some real creative thinking and a lot of listening.
And I think I'll just add that this is something that we work really hard with our prescribers on. And what's been really fun is having someone with lived experience on our supervision calls with the doctors, and they actually love it. And to really, so that at the level of supervision, we really try to engage the kind of the real live experience with medication in at multiple levels.
Yeah, I think actually that shared decision-making concept is a really interesting one that's evolving. In fact, we're about to start our own little project with our graduates where they're going to be developing a series of decision modules, kind of similar to the work that Pat Deegan has done, but a little more comprehensive around participation in the treatment planning process, and really kind of talking from the lived experience perspective about some of those treatment decisions and kind of how they work their way through them. So that it's a real learning process for us as well. But of course, you also do have folks who are at pretty high risk, and there are times where, where they really do need medicine in order to be able to stay safe. And so we definitely pay attention to that risk as well.
And that I echo that. It's some of the individuals that we work with, are have had histories of violence and have very, very frightening thoughts, and we must address that.
Yeah. So, do people have any other questions at this point? We still have about 20 minutes left, which we don't necessarily have to use fully, but I could add, related to the discussion about acuity, that we also have a more comprehensive risk assessment process that we use with folks where early on, our very first week that we started, we had our first death, and it was a person who we thought was low risk. And so that really led us to focus in on paying attention to things like if someone is delusional, what's the content of their delusions? Do they have access to car keys? The fact that Tylenol is highly toxic, and if you have a big bottle of it in your cabinet, that may put people at risk. So we've really also emphasized risk assessment at the initial stage and throughout. So Ryan, is there anything that you would want to add that we haven't covered?
No, I don't think so. I think this was good. I might add just follow up on a couple of questions around some of the medication use. We also have guidelines around that group that's in that at-risk category, or that psychosis risk category around prescribing. I know it's somewhat controversial that that group not be given medication, so we definitely have some guidelines around that too, and that we do I agree with you, or that we do a much more comprehensive risk assessment, which was basically taking one of the original risk assessments developed by McGorry, and then we kind of added a little more intensive elements. So, yeah.
And to sort of follow up on the issue of medication, I think one of the most sort of clinically challenging aspects of this is working with the families and the young people together, and that really takes it's not it's hard enough when you just got one individual that you're working with, but then you have a family at the table as well, and it takes a lot of kind of listening, sometimes negotiating, navigating the different people who really have a stake in what happens, and ultimately fundamentally respecting both the individual young person and their family. But it can get not everybody always agrees on what the right step is. So
I think that's a good point. And Mark has asked, speaking of the family piece, could you describe a little bit more as to what the family education piece looks like?
I'm very passionate about this, so I have to take a deep breath. I've done a fair amount of work over the years in kind of how to sort of optimally include families in care. And I would say that the foundation of the family work is both to be starting to be person-centered, so it's always kind of understanding what the individual wants, and also then working, finding out what the family wants and needs. And I don't think a one-size-fits-all works. And so one of the things that we've worked on in the Raise Connection project was based in work that we did in a project called Reorder, where we worked with clients who either didn't want their families involved or were ambivalent, and we did kind of a shared decision-making approach with them, where we helped them to understand what their recovery goals are, and then help them to think through the advantages and disadvantages of including their families. And I always say, if someone asked me if I wanted my family involved in my care, I would say it depends. You know, I would want to specify that. I'd want to play a role. And that's part of, you know, kind of notwithstanding the fact that we are working with children and we have to deal with the requirements, we always try to kind of start with the young person and kind of have them work with them to define the rules of the road. And then having done that, you know, we then try to do the same with families. And I think what we found is that when we approach it that way, we really get almost 100% family participation. In fact, we get 100% family participation. And then, you know, what is the menu? And here again, a menu is important, not a one-size-fits-all. In some cases, there's just, you know, checking in at sessions. In other cases, it's, you know, regular meetings. In other cases, it's that plus some psychoeducation. We also offer kind of a family consultation model to work on specific problems that might come up. And finally, we offer monthly psychoeducational family groups. But I think the key principles are starting with a young person centeredness, and it's particularly important with young people as they're, you know, individuating and separating, and yet, you know, they're so very often need their families desperately to help them through this. Again, a family-centered piece, and then a menu that, you know, can be very low intensity at times. So that's kind of the foundation. So groups, individual, PRN, crisis availability for families.
Okay, so this is Tamara. I will say that we have definitely found multifamily psychoeducation to be extremely powerful in helping to bring together the perspectives of the young person and family and to resolve some of the conflicts that are inherent in that. So we definitely, we do both single and multifamily psychoeducation. And we spend a lot of time kind of thinking through these types of issues. Like Lisa was saying, it's very rare that someone ends up not being willing to include their family. And Ryan's actually become kind of a master in how to create like a series of releases of information, you know, where it's like, okay, you're in the hospital, but you don't have any clothes, so can I have a release of information to talk to your mom about clothes, and then gradually reaching to the point where, you know, they're really actively involved in the treatment planning process. So we also sometimes will coach families in situations where the person is not willing for us to share information about them, but we're able to talk generally to hear what the family is saying, to educate them about things like releases of information, and to do some problem solving without divulging things that we're not allowed to divulge. So we really try to be very creative and flexible while staying within the legal requirements.
I know that our manuals, and I'm sure yours as well, include a lot of tools and materials for families.
Right, definitely. And Bill was asking whether we've experienced situations where a young person has been in foster care and doesn't have a viable family connection. Definitely there are times where people don't have a viable family connection for a range of reasons. Whether or not they're in foster care, or sometimes they're in more of a homeless situation, or just a situation that's not viable. And those are more challenging situations for sure, especially at the point of transition. And I think we need, as a system, to really be paying attention to what the larger system of care for young adults looks like, particularly related to folks who are at risk of homelessness. That family connection is so critical. So, thinking about, who can be a surrogate family member for that person, who, helping them to build family connections is really, really important. And we do have people come to multifamily groups who are not family members by biology or adoption.
Now, I think that question really raises a whole other set of issues that we've struggled with. In some sense, obviously our goal is to help people become, in some sense, to remain free of the need for, all the services, public mental health system, supports. We want, our goal is to help people become, independent, contributing citizens. And but many people who experience psychosis have a variety of other needs. Other than their psychosis, they have, real problems with poverty and problems with, again, homelessness, and so, it's this challenge of trying to help that individual get the services that they may need to shore up other aspects of their lives, whether that be income or, even other disabilities. But without, while maintaining that sense of independence, autonomy, self-efficacy, and agency. It's a challenge, particularly when people may have who have many types of economic and social challenges. So.
Yeah, I think once you get into this work, it definitely is a career. One of the things that's happened with EASA is that the legislature got interested in all the folks that EASA was screening out and paid for four regions to pilot a transition age youth system that tries to capture the folks who are screened out and then also is available to folks who have transitioned out of EASA to try to address those more comprehensive needs. And yeah, I think that this is really new territory for everybody. So, and I think actually Mark Fagan, who's on the line, is probably one of the world's greatest experts in that. So you may want to do another webinar coming up. So other questions? We have just about 5 minutes left. And I see someone typing. Oh, yeah. All right, thanks, Mark. Well, the one thing about being part of this whole network is that there are an impressive cast of characters. There are people who have achieved a lot of expertise in different areas, and having that kind of a learning system where we have multiple people sharing that expertise really allows us all to benefit. So as Lisa and I are talking, I'm thinking of things that I may want to adopt from what she's saying, and it makes it a really dynamic process, which is and it's a lot of fun. So I hope that you guys will still be with us in 5 years. So we'll give you guys a few more minutes to see if anybody comes up with any additional questions. Ryan, do you have anything you want to add?
No, not at this time. It's a really great question.
Yeah. Yes. So we do have someone typing. Will we get PowerPoint? Yes, you will get the PowerPoint, and there's also a recording that will be posted on the EASAcommunity.org website, along with all of the previous webinars.
And I wanted to acknowledge the leadership and work of Tamara, who has been doing this for years, and I just think Oregon's really lucky. Thank you. I also want to encourage any of you guys listening to, I know, please feel free to email me. I'm sure Tamara feels the same way. And I'm embarrassingly rapid in my response to emails. So it tells you a little about my life. But anyway, I mean, it really, don't hesitate, please.
Yeah, I've never met so many people who work on Sunday nights. It's really kind of ridiculous. But yeah, and the other thing, as people send emails, we also we're also trying to connect people up with the resources that are out there that may be more relevant to the questions you're asking. So we'll definitely try to help connect people. So Ryan is typing. Oh, and Ryan is asking everyone to like us on Facebook. It's a personal challenge he's taken on. In fact, instead of wishing me a happy birthday, he asked everybody to like us on Facebook for my birthday, which I thought was kind of generous of him. So, okay, well, we have 2 more minutes, and hopefully some of you will join us coming up. I know that as you get deeper into the material and trying to answer the questions that you have, that you'll have other questions. I know there are also a few questions that people have already sent where I'm working on the response, so I have not forgotten about you, but I'm trying to compile the appropriate response. I know, Bill, you had asked for some data, and there was also a pretty strong interest in peer support, and we put the word out and got about 15 responses, so I'm trying to kind of put that all into one document to send out.
And we'll provide some information on the fidelity/outcome tool.
Right. Yeah. So we'll follow up on the questions that people asked today. And thank you all so much for joining us. It's exciting to be part of a national movement.